Thank you, Mr. Chairman, and thank you to the panel. It's a great discussion. I had the opportunity to listen in my office to a lot of the discussion this morning, particularly the integrated model concept that we are talking about today, and was so appreciative of my colleague, Senator Cornyn, asking Dr. Trestman the question about why it's important, and that's where we need to start, obviously. But let me ask you this, Dr. Trestman, how would this integrated model help us alleviate the existing workforce shortage, would it?
I think it'd go a long way to helping, Senator, and thank you for all of your work in this domain. The opportunity is this. If we partner psychiatrists with appropriate support staff, embedding into primary care, we can keep people in primary care without them having to physically be seen by psychiatry. One psychiatrist for 2 or 3 hours a week can review a panel of between 40 and 60 patients to provide adequate support to the primary care team so that we can give guidance and support them. Additionally, something that was already addressed was workforce burnout,
right.
Keeping people in play, keeping them satisfied with their work. It's morally frustrating not to be able to refer someone to care. If you're the primary care doc, you see someone who needs care, it's beyond your scope, and you can't do it. The collaborative care model and other potential models allow primary care to do what they want to do.
Thank you. And Dr. Resnick, I appreciate your comments regarding the burnout issue and the pre-authorization. I just had some doctors in my office talking about the concerns about this prior pre-authorization requirement and how frustrating it can be. So thank you. But can I jump to, I only have about 5 minutes. I want to jump to rural Nevada, which is similar to Northern California. And so let me, Dr. Rideout, let me ask you this, because as with the integrated primary care, telehealth has proven to be valuable tool for rural Nevada in my state, and essentially to also extend our mental health workforce. And while we're making steps in the right direction, I am concerned that the telehealth and expanded primary care alone will not meet our workforce needs, particularly in our rural communities when it comes to behavioral health professionals in the long term. So in your view, how are contracting issues driving the supply problem in rural areas? How do we address that?
Well, I would agree with you that despite the huge uptick in telehealth visits, it's not going to be enough to solve the supply problem. And as I think a number of panelists have mentioned, primary care physicians, and I'm one of them, do provide a certain level of mental health care, but they too are burning out, they too are aging out. So you've got essentially stopgap measures. And I think in terms of contracting, in my experience across plans, purchasers, and providers, it's the conditions of participation, including rates, but not limited to rates, that really drives whether people want to participate or not. We've heard that psychiatrists, which are actually a relatively small percentage of the total mental health providers, it just costs too much to do it. I would bring back a thought of integrated care. We've talked a lot about integrated care in terms of medical and behavioral integration. There's also an integrated care model where physicians of multiple specialties practice under one organizational structure in an organization that's large enough to provide telehealth, large enough to provide data analytics, and large enough to essentially cover some of the shortages through better contracting or better load management within the group. So I think that's hard in a rural area because people don't concentrate that way in terms of practice. Very, very well.
Thank you. Dr. Resnick, did you have a comment?
Well, Senator, I'm really glad you brought up contracting, because when we look at the data, and AMA produces these data every year, most areas around this country have highly concentrated insurance markets where 1 or 2 plans cover the vast majority of patients in that area. So they're really, in rural Nevada or in big urban centers, there's not meaningful contracting. And we have physicians who have a big panel of patients, and the insurer just sends them a letter at the end of the year that says, thanks very much, we're done with you. Or it's really take it or leave it contracts that they present that increasingly are lower and lower percents of Medicare. So it is not a level playing field between the physicians who actually want to be contracted to be able to take care of their patients and the health plans.
Well, and it sounds like we need another panel of health plan providers to be able to talk to, and I look forward to that opportunity. Thank you, Mr. Chairman. Thank you.
Thank you.